So welcome everybody to the West Coast Fellows Conference. This is the first edition of 2024-25 class. So hopefully there are some new faces that are going to start trickling in. And for those of you who are new to this conference, it's something that we started way back in COVID when the fellows weren't able to go to really any conferences because of travel restrictions. And all of the Zoom conferences were on East Coast time. So none of our fellows could participate in any of them. And so we started this to kind of allow fellows to have access to some folks on the West Coast and the Pacific Coast time frame, and we just kept it going. So I think this is our 26th iteration. So welcome everybody. Today we have Alekos Theologis from UCSF. He's one of our few repeat speakers. Very pleased to have him. And appropriately, to kick off the new year, he's very much a West Coaster. He's an alumni of Stanford, did both medical school and residency at UCSF before briefly going to St. Louis for his spine fellowship at WashU, and now is back as faculty at UCSF. And we're going to get one of his residents as a fellow next year. So awesome to have you as part of our small family here at Alekos, and really appreciate you talking about Scheuermann's kyphosis. I think that's like a perfect fellow level topic. And so without further ado, I'm going to stop sharing my screen and turn it over to you.
Excellent. Well, thank you, Hani, and the whole group down there. It's an honor to be able to be a repeat speaker. So I'd love to come back. Let me bring up my screen here, and we will get going. So I have a lot to cover in a short amount of time, so I'll go quickly and keep it concise. So just quick outline. We'll talk about background, where did Scheuermann and the name come from, talk about some proposed etiologies from it, for it, and then talk about the clinical presentation, which is very important, followed by the workup and what's involved in that, what's necessary, what's not. And then also touch upon management, what the utility is of non-surgical management and really operative management. And then also take a deep dive into discussing some of the common complications and ways to prevent it. So I always like to start with some history. So Scheuermann was a Danish surgeon who proposed this phenomenon, and there's a lot of uncertainty around what was causing it. It initially was called muscular kyphosis or apprentice kyphosis, and he proposed that it was caused by disturbances in the vertebral epiphyses and not, as originally suggested, by muscular spinal insufficiency. He suggested that the pathology resembles Kyphosis osteochondritis deformans juvenalis coxae, which is a mouthful, and can therefore be labeled as osteochondritis deformans juvenalis dorsi. Now, there was debate back then, and there continues to be debate around the etiology. And I think ultimately that is because it's a multifactorial disease. And it's important to understand, what are the proposed causes of it that may influence its development. And those come in three major flavors: cartilage and bone disorders, mechanical disorders, and genetic. And under the cartilage and bone disorders, osteonecrosis of vertebral apophyseal ring, juvenile osteoporosis, cartilaginous matrix disorder, mechanical, excessive axial spinal load. Many of these patients, especially in the teenage years or young adults, are obese. Shortening of the ischial musculature and reduction of sternal size have all been proposed. And then genetic, I think this is one thing that's more agreed upon, that it does have a genetic component to it. So it's also important to understand the radiographic definition for Scheuermann's kyphosis, and very classic Sorensen's criteria, also a Danish surgeon. And amazingly, he developed this after evaluating over 4,500 vertebrae. And the three parts of this are wedging greater than 5 degrees in 3 consecutive or more than 3 consecutive vertebrae, thoracic kyphosis greater than 40 degrees, and then irregularities in the vertebral end plates. There are two types of Scheuermann's kyphosis. The most classic is type 1, as you see on the left, which is isolated to the thoracic spine. And then there's type 2, which is a little bit more rare, however, more functionally debilitating in many ways. and it's centered at the thoracolumbar junction or even the lumbar spine. The presentation of this disorder varies. As you can see on the right, there's a very classic external appearance with very prominent back prominence. This can be hidden, especially in patients who are overweight. You can see that there's anterior shoulder infolding. And then because of this localized deformity, a lot of the compensatory mechanisms associated with it, say cervical lordosis, lumbar hyperlordosis that are associated with it, can cause pain. One of my patients, his major complaint was that he couldn't lay his head flat on a pillow because of how prominent his thoracic spine. So he had to sit up, prop up 3 or 4 pillows to just keep his head in the bed. And then the neurologic symptoms are also ones that need to be evaluated. And I put rare question mark because I'm not sure how rare it is. It's a rare disorder in general. So overall, there's not a lot of people that we see with it. But this is a nice study from the WashU group back in 2014 that said that an abnormal neurologic finding was found in 9%. So 1 out of every 10 had some change in neurologic function, emphasizing the importance of performing a detailed preoperative neurologic examination. The workup involves assessing the flexibility, and you can get this with standing extension x-rays, the classic bolster supine lateral radiograph induces hyperextension, and this will just give you a sense of whether it's actual structural or if it's more posturally based, plus give you some insight into what your anticipated correction may be if you do perform surgery. And then an MRI can be involved in the workup, definitely if they have a neurologic impairment present. And then it's debatable if it should be obtained if there's no neural symptoms. But one of the benefits of getting it, even if they have neurologic symptoms, is you get to see if there's any asymptomatic disc herniation, stenosis, and a syrinx. This is a nice study in the Spine Deformity Journal in 2017 from a lot of familiar names in the pediatric deformity world. They evaluated 86 patients with Scheuermann's kyphosis who had pre-op MRIs and those who did not. On the patients who had pre-op MRIs, they found 17 spinal cord abnormalities. You can see the findings there: low-lying conus, syrinx, and then disc herniations in not an infrequent number of levels. And they found that about 5%, only 4 patients, but 5% of the group, the operative plan changed secondary to the findings of the MRI, either for neural compression, a disc herniation that they saw, or the spinal cord being draped over the apex. They did find that there were similar rates, though, of neural changes in patients who had preoperative MRIs and those who did not. This is a very striking case report from Dr. Tribus, and he reported on a 16-year-old boy with progressive Scheuermann's kyphosis who was undergoing a T7 to T12 anterior and posterior spinal fusion. And when he was performing the posterior aspect of the operation, all SSCPs were lost. And they performed a wake-up test, and the patient had no ability to move their legs. So they took out all the instrumentation and then closed them up, took them to the recovery room. And by the time we got to the recovery room, everything was normal. On the 3rd postoperative day, they had a CT myelogram, and they found that there was severe thoracic stenosis from T8 to T10. That was then followed by him returning to the operating room to undergo the posterior instrumentation, but they also included a decompression. And everything after that was A-OK. And because of this report, they stated that the author obtains a thoracic MRI before the surgical correction of any patient with Scheuermann kyphosis. So in terms of the general treatment algorithm, this is rough, and there are definitely nuances to it, but how I think about it is if the patient has less than 30 degrees of thoracic kyphosis, adult or kid, I think starting with observation, pharmacologic management, and then physical therapy is reasonable. If they have more of a moderate kyphosis, 60 to 70 degrees, then in children, you can consider bracing. And then in the adults, I wouldn't recommend that. And if they have greater than 75 degrees, you can definitely consider surgery, especially if they're symptomatic in the adult or the adolescent population. Now, surgery can be considered for all of them if non-operative failure occurs. if they have intractable pain despite non-operative measures, unacceptable cosmesis, and also deformity progression over time. I think a neurologic deficit probably for any group would definitely warrant surgery. And then cardiopulmonary distress, that is not a very common finding, but if it becomes so severe, that could be an isolated indication for doing the operation. In terms of the natural history and long-term follow-up of Scheuermann's kyphosis, this is a nice study from Iowa. 67 patients, you can see the average follow-up was 32 years, minimum of 10, maximum about 50. And they compared them to an age and sex match control. And they found that Scheuermann's kyphosis patients had more intense back pain, jobs that tended to have lower requirements for activity, and then patient less range of motion and strength, the trunk extension and different location of pain. And this is comparing patients who had non-surgical management to those. There were no difference in the number of days absent from work because of pain. Extent pain interfere with the ADLs, some self-consciousness, self-esteem, social limitations, use of medication for back pain, and level of recreational activities. They did find that those who had kyphosis greater than 100 degrees with an apex in the thoracic spine did have evidence of restrictive lung disease on PFT testing. So the question is, you have a patient who comes into the clinic, 55-year-old gentleman, 85 degrees of thoracic kyphosis. He's clearly lived with this his entire life. And the question is, well, what to do? And what are the surgical options if you are to consider them? So they come in two major flavors. There's anterior release and followed by posterior instrumentation. So the anterior posterior, and there's posterior only. The traditional approach was an anterior release, and this is shown in the thoracic spine. Now, this is somewhat of a lost art in some ways, but an anterior release is one where the ALL is released, the disc is removed, and then you place some cancellous morcellized graft, no structural cages. So we're all used to ALIFs and direct laterals and ATP approaches where we put a cage in. This doesn't involve instrumentation, it just involves releasing the disc so that when you do the posterior operation, things are loose and you can kind of manipulate things as you wish. This can be done through a open thoracotomy approach, or it can be done through a video-assisted thoracoscopic surgery. This is a nice study from Alvin Crawford, and he studied 19 patients who underwent this. He removed, on average, eight and a half discs, and demonstrated good results with this. And it definitely is a viable technique, but it definitely has a learning curve, a lot of instrumentation associated with it, but it is something that is a viable option. Now, when we look at combined anterior and posterior fusions for kyphosis, this is a very old study from Hall from Harvard, and demonstrated that doing an anterior posterior operation provided good results. Bradford, when he was at Minnesota, also put out a nice study looking at results of patients who underwent anterior and posterior operations, and demonstrated that significant loss of correction did not occur in the fusion area, which is always a concern if you don't have anterior structural support. The argument against an anterior approach is that there is quite a bit of approach-related morbidity, pain, the pulmonary function can take a hit, and then appearance, especially if it's a large open thoracotomy, that can leave a pretty significant scar. It does increase operative times, and also increases EBL, just inherent in two stages. And it begs the question of, well, is it truly better? Does it provide better correction? And then subsequently, can the same correction be achieved with posterior only? Now, similar study from Bradford demonstrated that posterior only operations back then in the 80s actually did not provide great results because there was loss of correction over time. And I believe this is secondary to the instrumentation. You can see all hook instrumentation, and the correction at that time, not having segmental fixation throughout, probably was one of the reasons why the correction was not as great. But Conti proposed an osteotomy where you remove the interspinous ligament, the supraspinous ligament, the inferior articular process, and superior articular process to release the spine. And then with new, more modern instrumentation, pedicle screws you get 3-column fixation, cantilever bending provides pretty significant correction, and it results in the discs opening anteriorly. But how much do those discs really open? This is a nice study from Newton in San Diego in 2011, and he looked at segmentally every disc in the thoracic spine down to the lumbar spine in patients with Scheuermann, comparing those who had anterior release followed by posterior fusion, instrumented fusion, and those who had posterior only. And the dots and the squares are pretty much the same. And so they concluded that the addition of anterior release did not significantly alter the degree of correction of the disc space changes. This is also a study from WashU group in 2006, and it compared Scheuermann correction by posterior only thoracic pedicle screw fixation versus those who underwent anterior and posterior. And the box with the red concludes that with less operative time and intraoperative blood loss, posterior only treatment with thoracic pedicle screws achieved and maintained better correction and had significantly less complications than circumferential fusion. This is a systematic review of those patients comparing posterior only and anterior and posterior, and looking at those who had no osteotomy and those who had Ponti or some form of PCO, et cetera. And you can see the plot on the right. In those patients who had no osteotomy, it actually favored an anterior and posterior. If they had a osteotomy, it was somewhat neutral, maybe a little bit favoring the posterior, but all in all, you see the red diamond, it's a wash. And then if we look at types of fixation, hybrid constructs, hooks and screws versus screw only, again, neither one was superior. So again, they didn't look at only hooks. It was a hybrid, but it does show that either construct from the back provides the same equivalent correction to anterior and posterior. I had to throw this in. This is an article that I read last week in the European Spine Journal from Turkey. And this is only an option in children who still have growth potential. But there's been a big fad in the AIS world of using vertebral tethering anteriorly to correct gradually the idiopathic scoliosis. This was the tether was used posteriorly to correct Scheuermann's kyphosis. Small patient population, 10 patients, average age, you see 13 is still with growth potential, minimum of 3-year follow-up. And here are the specifics of what surgery entailed. Average duration of the operation, as you can see, about 120 minutes, 2 hours. EBL was pretty minimal, 135 cc's, and length of stay averaged about 4 days. This is a picture from their paper, and you can see here that immediately after surgery, there was correction, which just inherently shows there's some flexibility to the kyphosis. But then over time on the right, at 4-year follow-up, that correction continued to improve. For the whole group, the averages are shown on the upper table. Preoperatively, average was 74 degrees. First postoperative was about half of that, 44. And then over time, there was improvement for about another 10 degrees or so. It does beg the question of, maybe too much correction, overcorrection. Classically, the teaching is you want to correct by not more than 50%. And I do wonder if over time, if these children continue to grow, if the thoracic spine will become too flat, and that will set them up for PJK and DJK. They didn't discuss that in the article. And they said that this was a viable alternative to fusion in skeletally immature patients with Scheuermann's kyphosis. I think this is definitely food for thought. I'm not advocating for it. And I would not do this on your boards because I'm not sure you would pass. And that brings us to, what is the utility of surgery? Does it help? And there's many studies that demonstrate that surgical intervention for adolescent Scheuermann's kyphosis does improve quality of life scores. And there's greatest improvements in pain and self-image domains. And if compared to healthy individuals in the study on the top, levels of pain and activity reach the same levels, while function and self-image remain at a statistically lower level. So it's improved, but not back to, I guess, quote unquote, normal peers. And then bottom image demonstrated that the use of a PSO to correct severe Scheuermann's thoracolumbar kyphosis provided significant improvement in self-reported scores of pain, self-image, and the mental health domains in the SRS-22. This was a prospective study comparing those patients who had operative treatment to non-operative treatment, and they found that surgically treated patients at 2 years have better improved SRS-22 scores, less pain, greater satisfaction with appearance, and greater satisfaction with overall outcome. So if surgery is done for the right indications, it does, and it's done technically well, and you avoid complications, it can provide significant improvement in their quality of life. So this is back to the gentleman, my patient, 85 degrees of kyphosis, and a lot of pain, underwent a T2 down to L3 posterior instrument fusion with about 40% improvement in the kyphosis. And he's able to go back and play piano and was a happy camper. And he's about 5 years post-op now with no issues. When things go well, they go what that's nice, but unfortunately, things can go awry not infrequently. This was a report from the SRS M&M database and patients with Scheuermann's kyphosis who underwent surgery. You can see on that bottom right that all comers, the complication rate was 24%. The complication rate increases with increased age. So adults have higher rates of complications compared to children. Kids less than about 12%, whereas those greater than 35 had a rate of 26, 25% or so. Wound infections, other, unfortunately, I can't tell you what those are. And then neurologic, you can see here about 4%, which is not infrequent. The two major failures, in addition to the ones presented there, that are important to understand, because there are ways to try to prevent these, are PJK and DJK. And you can see the rates down there are pretty staggering. They can be caused by a variety of factors as listed on the right. Vertebral body fractures, posterior ligamentous complex disruption, soft tissue issues, progressive distal or proximal disc degeneration, so natural adjacent segment disease, and also non-union at the last instrumented level. Risk factors, mechanisms, also multifactorial. Selection of levels is very important, especially in Scheuermann's, which we'll touch upon shortly. Failure to restore sagittal alignment specific to the patient. This hasn't taken into account pelvic incidence, Russo-Lee classifications, thoracolumbar junction orientation, etc. Implant rigidity, trajectory of the LIV screw, anatomic versus straightforward. Anatomic, in my opinion, that the LIV increases the risk for more of a windshield wiper effect with the cantilever forces that occur on that distal screw, and then TP hooks compared to proximal screws. Amount of correction we talked about is important, body habitus, and then there's probably some neuromuscular disorder that contributes to this in some patients. So PJK prevention, so level matters. For the thoracic based, and you could probably argue for thoracolumbar based type 1A and type 2, that selecting the proximal UFB at T1 or T2 is better. And then again, getting the sagittal alignment, the profile, and the shape of the spine correct is important. You want to, we won't go into the nuances of this, but you want to aim to correct the kyphosis close to the patient's PI. There's a lot of nuances to this. DJK prevention, this is a very hot topic, and there's two ways of choosing it. There's a stable sagittal vertebra, the SSV, as you see on the left, and that's defined by choosing a level that is bisected by a line that is drawn vertical from the posterior superior corner of the sacrum. You can see that little star is the stable sagittal vertebra in that image. That's more recent way of choosing the LIV. The original one was to choose the first lordotic disc, as you see on the right. These are several studies looking at the DJK rates of those patients who had an LIV at or above the stable sagittal vertebra and those who had it below. And you can see that the DJK rate in general was high, 16%, but in those patients who had it at the stable vertebra or caudal, had a much lower rate, 5% of DJK compared to those who had their LIV above the stable sagittal vertebra, 36% DJK if you stopped short of it. Looking at the same concept, and they concluded in WashU that levels that include the first lordotic vertebra but not the stable sagittal vertebra are not always appropriate to prevent DJK. This is a nice image from their study, and on the left, this is a patient with thoracic kyphosis. The first lordotic disc is at L2-3, where the stable sagittal vertebra is at L4. And they chose to stop at L3. You can see here that they had non-union and progressive distal failure at L3-4, necessitating a revision down to L4. This is also a patient with Scheuermann kyphosis, 82 degrees. You can see on the left that the first lordotic disc is L1-2. At the time when they were doing these operations, that was the only concept of choosing the LIV, so they stopped at L2. But the stable sagittal vertebra is L3. And you can see on the right that there was distal junctional kyphosis because they quote unquote stopped short. And then they had to extend it down to L3 or L4. In addition to choosing levels for DJK, are there other options for preventing it? And in the adult deformity world, especially in the upper thoracolumbar, long thoracolumbar instrumented fusions, doing tethering or cement augmentation has been implemented and debated. And the question arises, well, should it also be used in this setting? Cement augmentation of the LIV, and then should there be an interbody fusion between the LIV plus one LIV? And then the question of sublaminar banding versus hooks versus wiring at the LIV. I think we can definitely debate whether this has any utility. I don't think there's any studies that have looked at this. I have started to implement it. This is quite an obese gentleman, mid-20s, who came with Scheuermann's kyphosis, and we stopped at L3, did an L2-3 direct lateral, and then cement augmented him, and he's several years, he's about a year out, and he hasn't had any issues. To critique myself, I don't think I corrected him perfectly, and maybe that's what protected the distal junction, or maybe the distal junction was because of the fortification, could withstand some of the cantilever forces there. So in conclusion, Scheuermann's kyphosis is one of the adolescents, but can also present persistent cosmetic problems and pain in adults requiring intervention. Surgery provides significant improvements in HRQOLs, pain, cosmesis, and mental health. And there are relatively high complication rates, including PJK and DJK. PJK prevention, stopping at the T1 or T2 for the UIV, I think is a good rule of thumb, and also making sure you correct the sagittal profile specific to the patient and their shape. And then DJK prevention, I think is still a little bit of a black box and more multifactorial, but LIV selection, stopping at the stable sagittal vertebra, getting their sagittal alignment correct, and then plus or minus fortifying the construct of the bottom with interbody support and cement augmentation. So thank you, and happy to take any questions.
That was awesome. Thanks, Alekos.
Thanks, Alekos.
My pleasure.
Well, hey, are you guys still contemplating using the end plate? In other words, a cephalad directed screw to get better purchase at the base? I know Ames had talked about doing that. I'm just not sure if he's still doing it.
Yeah, I think that was a fad. I think
Yeah.
the concept makes sense.
Yeah.
I think technically it's hard especially when they're very lordotic.
Hmm.
And getting the angle, it's almost like putting a C12 transarticular screw in.
Absolutely.
It takes a lot of, I think it's challenging just technically, and I think it ultimately didn't show any improvement.
Difference. Yeah.
Yeah.
Got it.
All right. Any other questions from the group? Any of the fellows?
Yeah, I have one. Dr. Theologis, this is Youssef, one of the spine fellows at SDSF. Great talk. Thank you so much for going in depth in that. It's something that is always kind of lightly touched on in residency and for boards prep, but never really to this degree. So thank you for that. I also wanted to just comment. It's kind of funny, being a med student with you when you were a spine fellow and now being a spine fellow myself. So it's kind of nice to have.
Circle of life.
Yes, nice to hear. It'd be nice to see your face, but I understand the Zoom constraints. But good to see you, and enjoy your fellowship.
Thank you.
You're going to work with a great group.
No, very excited, very excited. But I did have a question. In an age where indications are becoming extremely important, and we're hopefully operating on the right patients. How are you navigating? You know, Probably in more of the pediatric population or the adolescent population, people are coming in with primarily cosmetic issues who are kind of not necessarily feigning pain, but knowing that that's a buzzword of maybe get potential operative intervention, like, oh, I have a lot of pain, functional pain and stuff like that. It's things that we're seeing. I know that we saw in residency in the AIS population. So how are you kind of navigating those patients to really, make sure that you're appropriately operating on those patients?
Yeah, that's a great question, and you're going to learn more about that this year. But one way that I try to assess whether surgery will help with pain that's associated with the deformity is there's some clinical exam findings you can do. One is, which is very crude, but you can lie them on their belly and press on the actual area. So press on the kyphosis. That may or may not elicit pain. If it does, that could be a sign that that is the source of the pain. The other thing you can do is ask them when they lie down, does the pain improve? So there could be some mechanical instability, if you will, to the deformity. Pain that is there all the time, day and night, I think is a red flag.
Okay.
I always get concerned about operating on that. But deformity-based pain is either from the deformity or from the compensation to the deformity, and it can be hard to tease out. If you have any, doubts about the patient or the families, if it's a kid, their intentions, you can kind of slow play it with them. Send them for a couple studies. If they do them, they're good citizens. They come back on time. They don't cancel appointments. Then and you get a good sense from them. Then they may actually not be faking it. But I wouldn't jump if you have any question marks. First time you see a patient, I would be hesitant about signing them up for surgery right away.
Got it. Great. Thank you.
Hey, Alekos, Venu.
Oh, sorry.
Hey, Venu.
Oh, sorry. Hey, how's it going, man? Really great talk. Thanks so much. I wanted to just ask a question about how you think about in the older population, let's say 55 plus, when to consider going down to the pelvis versus stopping at the sagittal stable vertebra. I feel like a lot of the adult patients will already have some degree of degeneration in their lower discs. And so how do you think about and how do you make the decision whether to extend someone down to the pelvis in some of these older patients who may have had untreated Scheuermanns in their teenage years?
That's a good question. I actually see more of those patients than I do the adolescents and the kids. And that's a big debate. I actually did just someone 2 days ago that had that issue. A couple factors I include. One is their bone density. Number two is their weight. And number three is their degree of deformity. So if they're overweight, if they're osteoporotic, and if I expect a pretty significant deformity correction, I am more inclined to go to the pelvis. I do think that going to the pelvis provides probably a better base, and it probably allows you better correction of the deformity in the thoracolumbar junction of the thoracic spine. But it's a big deal to go down to the pelvis, especially if you're using T upper thoracic to the pelvis. So that's how I think about it, though.
Great. Yeah, I mean, I think that's exactly how I think about it too. I think lots of us will see many more adults than kids in our practices, and so these are tough decisions. So thanks.
Awesome. Well, it's 7:07, so if there aren't any other burning questions, we'll probably end it here. Thanks so much for everybody signing on, and we'll have another session next month. Check out your inboxes, and have a really awesome weekend, everybody. Enjoy the rest of the summer.
Thanks, guys.
Thanks, Alekos.